So are you ready for another exciting session? I did enjoy the morning session, and I am sure you did. Shout out if you enjoyed the morning section. Yes. So I know Caroline was trying to prevent me from asking the question. Now I'm chairing the afternoon, I can ask the question. So I hope you can understand my Ghanaian accent. Somebody said to me, if you have an accent, it means that you probably know 2 or 3 languages before you learn how to speak English. I said, no, the place I come from in Hull, they have an accent. They don't have any other language. So it doesn't work always. So we have some fantastic speakers this afternoon. So I'll tell you a little anecdote about why I'm passionate about research. So my name is Kwame. I am the Executive Medical Director for HAMBA and the lead for research. So a few years ago, which is about 15 years ago, I was trying to leave the 15 years ago. I was in a clinic in Hornsey, and I saw a patient who, after 3 attempts at antidepressant, said, got better. And I thought he was going to say, thank you for getting better, but he was curious. He said to me, how come it took 3 goes to get me better? And at the time, the explanation was, we used a bit of a try and error. But if you came to see me in 50 years' time, you would I'll probably have a portable device where I would take blood, maybe saliva sample from you, and you to tell me precisely which antidepressant to give you. And he took a good look and said, well, if there was this portable device, I'll buy it myself and I don't have to see you. I thought, and he was right. So the guidance has now improved, so you could move from try and error to actually prescribing based on guidance through research. Portable devices are becoming more cheaper, and most important, I wasn't that important to the patient. What the patient wanted was an effective treatment. So I thought he was going to see. I thought he liked me, that's why he came to see me. But actually what he was looking for, effective treatment. So the lessons learned is research health practices. Technology is improving, and AI is going to help us to be more effective and help patients in a better way. And more importantly, listen to your patients all the time. Co-production is one of my areas. Cognospeech is the next one. I'm really, really keen to hear about Cognospeech. It's fascinating. I've looked at the website to see your YouTube video, and I thought it's fantastic. So really, really looking forward to it. Over to you.
Thank you. Dan, hopefully, his video will come through, and he will kind of introduce Cognospeech to all of us, and then I'll talk a little bit more about specifically one of the areas that we're focusing on with individuals who speak English as an additional language.
Hi, I'm Dan Blackburn. I'm an academic neurologist from Sheffield, and I'm going to speak today about an automated assessment of cognition based on language. The current problem is that waiting times to be seen in memory clinics are very long, and this has been happening for many years, but during COVID, when memory clinics closed down, this has resulted in even greater delays. So people are often waiting many months, up to 2 years, to be seen in memory service. When the services did close down during COVID, they reopened using remote technology, even if that's a phone, which up to a quarter of people are still using phone assessments, and 11% are using video calls to measure people's cognition. The gatekeeper for being seen or being sent to the memory service remains a GP, and they typically use short questionnaires. And there's an example here on your screen of 6 questions that are asked. And there are a few problems with these sorts of tests in that, one, the GP has to find the assessment, they have to record it and then send it through to us. But also people who are high functioning have to deteriorate quite a level before they fail this test, and therefore they may not get referred until they've deteriorated for some years. And people who are anxious or worried or depressed or got poor sleep may fail this test without having any evidence of neurodegeneration and be sent to a memory clinic. And this shows a slide showing that a lot of people seen in memory services don't have dementia. So particularly in the under 65 population, up to half of people didn't have an evidence of dementia. And we've shown this from previous research. And we, in Sheffield, in my clinic, we see people aged under 75, and we see large numbers of people who don't have any evidence of dementia. And if we could recognize and reassure these people earlier, it'd be great for them, that they wouldn't have to wait for a year to be reassured, and it'd be easier to reassure them. They wouldn't have to come into hospital because we could do the assessment virtually from their own home. And it means that those people with dementia and MCI, whereby we may initiate treatments, be it tablet-based or other, could be seen at an earlier stage rather than have to wait for such a long period of time. And this is the basis of why we've developed CognoSpeak, which I've been working on for about the last 8 years with Professor Heidi Christensen, a professor of computer science. It's a web-based platform now that it gives you a choice of 4 virtual heads to speak to, and they ask questions that probe memory and other cognitive functions. It's easy to use. You can do it from your own computer, generally on Google Chrome, but it can work on an iPad, but not other tablets or phones currently, although that is our future aim. And it's designed to be low cost, accessible, and repeatable. And this is what the system used to look like.
Hello, I am the Avatar Consultant, and I'll be asking you questions today. This avatar is designed to reproduce what happens in the memory clinic. Thank you for agreeing to take part. I will start to ask you questions shortly.
So it's a very simple looking virtual clinician. There were some issues with lip sync. But despite that, we recorded several hundred people speaking to this version, and the back end used both acoustic, linguistic, semantic, and grammatical analysis to measure signs of cognition. And we published data a couple of years ago on 60 participants, 15 with mild cognitive impairment. This is people who've got cognitive impairment that is evidenced by them thinking they've got cognitive impairment, and when we test their memory, they score below standard cutoffs, but they're still functioning normally. 15 people with Alzheimer's disease, 15 healthy volunteers or healthy controls, and 15 people with functional memory disorder, FMD, or functional cognitive disorder. These are people who think their memory's not working properly, but when we do detailed testing, they score normally, and structural imaging is also normal. And of the accuracy of the original system was that it correctly identified people with Alzheimer's and MCI in 86.7% of the time, and it accurately detected those as healthy volunteers in 76.6% of the time. So this is very favorable to the typical test that people use in GP, and is pretty similar to the tests such as the MOCA and the Addenbrooke's. So I'm now going to hand over to Caitlin, who's going to describe a bit more about CognoSpeak, and in particular our work with ethnic minority groups. I'm very grateful that you've allowed us to speak to you today, and I'm sorry I couldn't be there in person.
Wonderful. So hopefully you've kind of got a bit of an idea as to what CognoSpeak is. So I'm going to talk a little bit about our work with the community groups in Sheffield. So my name's Caitlin Ellingworth. I'm a research assistant at the University of Sheffield, and Dan Blackburn, who we just heard from, is the lead primary investigator for CognoSpeak. So dementia is the leading cause of death in the UK currently, with almost 1 million people living with the disease. And this number is predicted to keep increasing over the coming years, most especially in ethnic minority groups. So we've looked into kind of the barriers to a dementia diagnosis for ethnic minorities, and to do this we engaged with many different workshops in ethnic minority groups in Sheffield. They discussed a lot about the social barriers. I'm not going to go too much into that today, but there is a lot of talk of the stigma surrounding having dementia, confusion as to what is the difference between normal aging and actually neurodegeneration. But one of the other barriers that people from ethnic minority groups can face is language barriers. So dementia as a term has different meanings that don't necessarily directly translate into other languages. And that can cause confusion and additional stigma to be added. But moreover, the assessments, so Dan mentioned GP assessments usually have about 6 questions. The assessments are almost exclusively conducted in English. And for those which are translated by a translator, again, it can be very difficult for the actual meaning of the questions and the responses from the participant to be said back to the doctor. And moreover, the memory assessment tools that are currently used in both GP practices and in secondary care clinics are overwhelmingly based on the norms of white English-speaking individuals, which doesn't necessarily translate to different groups. So one of our main collaborations in Sheffield was with a community group called ISRAC, and this is the Somali community group. ISRAC itself means unity. So we trained 2 research champions from within this community on how to conduct good clinical practice, and specifically the Montreal Cognitive Assessment, which is one commonly used in secondary care clinics to diagnose or help to identify those with cognitive impairment or dementia. The Roland Universal Dementia Assessment Scale, which is a more culturally tailored version of the MOCA, and the Multicultural Cognitive Examination, which is a more extended version of this RUDAS. So the research champions helped us to facilitate workshops surrounding what is brain health, what is dementia, and why would you want to take part in research. And from this, we were able to recruit 52 participants around the age of 40 years old from both Somali and British Somali backgrounds. So all the participants we asked to complete the MOCA, the RUDAS, the MCE, and CognoSpeak. So we didn't just ask them to take part in the research, we also asked them to help create CognoSpeak. So we co-designed CognoSpeak with the ISRAC group, where they gave us the feedback that just talking to one Dan-looking digital agent wasn't what they wanted. So from this, we've now developed 4 different virtual agents that all participants can choose from to allow for more comfort between talking to a different sex or different ethnicity of individual. So I'm just going to show you kind of an example of what the current version of CognoSpeak looks like.
Hi, my name is Mariam. Welcome to CognoSpeak. CognoSpeak is a digital tool used to assess people with memory problems. We will ask you some questions and record your responses. This is what we call the assessment, but there are no right or wrong answers. The questions are very general. We would like your answers to be quite long to help us have enough speech recording.
So a much more friendly and realistic version of individuals to talk to. We did find that there wasn't a massive difference in the preferences of the avatars across the groups who took part in CognoSpeak, but I think still having the opportunity to choose who you'd like to talk to is important for people to feel more comfortable when completing the assessment. So I talked about the pen and paper assessments, so the MOCA, the RUDAS, and the MCE, and this is the results that we got from our Somali participants. So how this works in a secondary care clinic is that there is a certain threshold score that you receive from the assessment, and if you score below that threshold, you're identified as being likely having cognitive impairment, and this might be mild cognitive impairment, so prior to getting dementia or dementia. And what we found was that 40% of the participants from this Somali community group scored below this threshold for cognitive normality, so would have been identified as having possibly a mild cognitive impairment, compared to just one participant not reaching the threshold on the MCE and one participant not reaching the threshold on the RUDAS. Strikingly, all of the participants who took part were cognitively normal. So this just really highlighted to us how inappropriate some of the current assessment tools that we use in secondary care clinic can be across different demographic groups who would be coming to clinic. And And within all of these cognitive assessments and within CognoSpeak, there is something called a verbal fluency task. So the animal fluency is asking you to name as many animals as you can within a minute, and phoneme fluency would be asking you to name as many words that begin with a certain letter. So in this case, it was P. So what you can see is the ISRAC group in purple compared to the English native speaking cohort in yellow. And what we found was that the Somali cohort scored considerably lower across both of these verbal fluency tasks. And we dug into it a little bit deeper as to what was kind of driving this, and some really interesting quotes from the participants came up. So the Somali participants said that a letter of P doesn't exist in Somali. So P is called like a bilabial phoneme. And in English, we have B and P. But in Somali, it's just B. So a lot of participants were scoring much, much lower on this task, not because they didn't have words that they could come up with, but because they were simply giving us B words, or they were misunderstanding as to what we were asking them. So after saying this to us, they went on to give no answers. So they scored 0 out of the possible total amount that they could get. Similarly, a participant on the animal fluency said that they knew the animals in Somali, but they couldn't translate it into English. So this highlighted to us that maybe asking for animals isn't always very relevant to people. I personally don't know how to say ocelot in Spanish, but I could tell you the names of foods whenever I've gone to visit. So we looked at different versions of verbal fluency tasks. So one of the versions used in this multicultural cognitive examination is called supermarket fluency, and that asks the participant to name as many items that they can think of in a supermarket. And we saw that across the levels of English language proficiency, the Somali participants scored much better. So from this, we kind of took that in order to make an assessment fair for people to be able to get the appropriate diagnosis, it needs to be culturally relevant. For someone to be able to get a good representation of where their cognitive skills are at, language shouldn't be the barrier to them being able to express themselves. So we kind of learned that using an appropriate memory assessment is critical for accurate diagnosis across different communities. So perhaps using the MOCA is inappropriate for people who speak English as an additional language, as opposed to something like the RUDAS and the MCE, which we saw earlier. We also needed to think about what phonemes or what letters actually exist in other languages, because if the individual's first language prevents them from being able to come up with the actual words in English, that unfairly disadvantages them. And the same thing happens with asking for animals as opposed to something which is much more common knowledge, like the need to be able to buy something at a supermarket. So Dan mentioned that CognoSpeak works on the basis of artificial intelligence. So the artificial intelligence analyzes both the content of the speech, so the words that are produced, and also the tone and the prosody and the grammar of the words. So in order for CognoSpeak to be able to correctly identify who is likely having cognitive impairment and memory issues, we needed to be able to make sure that the training that this artificial intelligence was given wasn't biased against groups who speak English as an additional language. So this is why we've been trying to actively encourage a diverse training sample. So not just individuals who speak English as an additional language, but the different accents within English also, to make sure that the automatic speech recognition works across the possible end users who would be using this as a screening tool to get to secondary care. So we've worked with the Somali community, we're actively now working with the South Asian community in Sheffield and in Bradford, and we're working with the Sheffield Chinese community. More recently, we've also looked at the accuracy of CognoSpeak in 126 patients, so 8 with dementia, 39 with mild cognitive impairment, and 79 who were healthy. And we found that CognoSpeak could accurately identify 100% of the patients who had dementia, 87% of those who had mild cognitive impairment, with just 5 being misidentified as being cognitively intact, and then 96% of the healthy controls were identified as being healthy, with just 3 being misidentified as mildly cognitively impaired, but no one was incorrectly identified as having dementia. Just showing the potential that with increased training we would be able to hopefully stratify this. So our recruitment's currently at just under 1,200, but it's overwhelmingly white British individuals who speak English as their first language. And we're trying to actively work with these different ethnic minority communities to increase both the trust in the research and desire to participate in it. One of our biggest sources of participants is Join Dementia Research, which was wonderful to see the video on that earlier, just to show how much of an impact it can have. The Humber team have also been incredible in helping us to actively recruit individuals with mild cognitive impairment, as this is one of the groups which is harder for us to kind of track down. It seems to be that limbo for a lot of people in comparison to recruiting patients with dementia or healthy volunteers. But we're always looking for more people to take part. So you may notice on your table there is actually a participant information sheet, so you can sign up to see if you are interested in taking part at all. So our future work is to work hopefully with more ethnic minority community groups across the UK to get that variety of accents. So I mentioned the Chinese, South Asian and Somali, but we're also going to be working with the Polish group in Sheffield. We just secured a small grant for that. We're going to be interviewing GPs to see how they think CognoSpeak could hopefully fit into their practice and the extent to which they think it could fit within the current memory assessment pathway. We're going to be trialling CognoSpeak in the memory assessment pathway to see if it can help to reduce that wait time to see a specialist and to help reassure those individuals who don't have cognitive impairment earlier on in their journey. And we're going to be doing longitudinal follow-ups to see if CognoSpeak can track the deterioration of individuals who do have a memory impairment over the course of the disease. So I'd just like to thank everyone who is part of the CognoSpeak team. This is only a small portion of us. So Dan Blackburn spoke earlier, and Heidi Christensen, they were kind of the creators of the current CognoSpeak tool, but there's many, many other individuals who are helping us. So it's Pratha and Catherine here today who have been helping us from the Humber site, but our research champions, Musa, Sarah and Ismail, have also been helping us from the Somali community. So thank you for listening, and if there's any questions, I would love to hear them.
That's brilliant. I think it ticks a lot of boxes for me. It ticks a lot of boxes of using technology to help make diagnosis and reduce the wait for patients to get assessment. It ticks the box of inequality and health access for me. And any questions? Any curiosity? Where's the mic? Have we lost them, Adama? Sorry. Catherine.
Thank you, Caitlin. That was great. And it's brilliant being involved in CognoSpeak because it's a really different thing for our trust to be involved in as well. Artificial intelligence is obviously the way forward for lots of things. I was just wondering, you mentioned that you move into wanting to engage more Polish participants, and I know you've got a little bit of funding for that, I think in Sheffield. I'm just wondering, because I know our research engagement nurse for Eastern European communities is in the room somewhere, and I just wondered whether it would be helpful for us to look out for Polish participants here, or whether you only want them over in Sheffield at the moment.
No, we definitely want as many people to take part as possible. We're still just in the very early stages of starting the recruitment from the Polish community, so we're going to be putting on some workshops with them to see how they feel about CognoSpeak first. But I'll keep in mind that you actually have someone here that I might be able to talk to about recruitment. Yeah, thank you. Oh, wonderful, Dan. Hi.
Oh, this is what is shown. This is what is online.
Yeah, it's you.
Thank you.
live with us.
Thank you so much for the presentation. I actually enjoyed it. I was just wondering, what about non-English speakers, or those that have very little English, speak very little English? What do we do for them? How do we assess those?
I don't know if Dan, can you hear us?
Yeah, it's a really good question, and we're taking some more steps there. So we know that the pen and paper tools don't work for them. It's really interesting. So we're the fluency task, which we've seen these biases. There's when the AI analysis it looks at both the acoustic signal, pauses, as well as the actual words. So we'll be able to do an acoustic analysis of people if they spoke in their first language. So that's a possibility that we're exploring. But getting the ASR to work, so the automatic speech recognition, will take a bit longer to work. But clearly the way forward is to have this available in people's own language. And we like CognoSpeak because it's interaction with conversation. It's not part of a test. And I think we want to develop in different languages, but it will just take time.
Okay, if no more questions, then thank you very much. Oh, is there more questions? Oh, sorry, I didn't see you. Marianne.
Hi, thank you for this. Just a quick question. You did say that the selection of the avatar made no difference. Did you consider that was because the voice behind the avatar was a Caucasian voice? So the accent was very English, it was very Caucasian. So could that have been a reason why it made no difference in terms of the selection of the avatar?
This is Dan. I would just say that when they choose the avatar, they don't know what accent the person will speak with, so they're choosing it based on what it looks like.
Anyway, I think it's a great initiative or research, and I can't wait to see it come into clinical practice in a massive way. I think the areas in which you are looking at in terms of the different accents, the different groups, is also honorable to hear. And I think colleagues here appreciate you coming to give us a talk here, Dan. And yourself. Thank you very much.
Thank you.
Thank you very much.
Okay, so the next speaker is they are joining us online, and I think they are taking on two wicked problems. I don't know how anybody would want to take these two together, which is loneliness, which is a wicked problem, and domestic violence, which is a wicked problem. But if you combine the two, and they want to address that, so again, I'm looking forward to what they would want to say about that.
Great. Hi. Thank you very much for your invitation to present today. My name is Austin. I'm here with my colleague Eos, and we're going to talk to you today about research we're doing on loneliness and other wicked problems. And really pleased to be giving this talk at the 7th Annual Humber Research Conference with you and your colleagues. So I'm director of the Self-Care Academic Research Unit at Imperial. I'm primary care public health research manager at Imperial College London School of Public Health. And since recently, we're doing a lot of work on social care. And I also have a role within the NHS. I just want to start by talking about some of the innovations in research infrastructure we established in Northwest London in 2019. On the left here, you see the Research Trailblazers group. This is a group we established in 2019 to spearhead the development of studies in the NHS setting. It's essentially an informal roundtable of stakeholders in Northwest London in the NHS, doctors, nurses, surgeons. We also have MSK and physician assistants coming to us with amazing research ideas that they haven't got the knowledge or the time or the funding to do it, but we have infrastructure funding to be able to appraise these ideas and develop some research projects from them. It worked so well that in 2023, we decided to establish the Research Pathfinders Group, which is a similar alliance, but it's really looking at research in non-NHS settings. For example, social care in local authority. And we're doing a number of things across the themes of tackling the cost of living crisis, men's and women's health, support for carers, oral health, and so on. And this was born out of the idea that we really need to move away from doing pure health research, which is very important, but we're very good at as a nation. We really need to start thinking about the care. So you can see here how the Department of Health has changed its name the Department of Health and Social Care. The NIHR, that you'll know, has also changed its name to the NIHR Institute for Health and Care Research, and so on. So we obviously are familiar with the study development cycle. We develop the research project, we do a literature review, a protocol, a study pack. We seek an opinion from an ethics committee, and then we begin to collect our data, analyze our data, we produce a report and papers. Ultimately, we hope to do enough work to begin to compete and succeed in getting funding from the NIHR and other competitions. So there's three case studies I'm presenting. Today, we're going to focus on the Measuring Loneliness in the UK study, which your group, and I'm very thankful, was very instrumental at helping us recruit for. There are other examples in the future we can talk about. For example, the work we've done on tackling domestic abuse, and some of the research we're doing on trying to engage with underserved segments of society when it comes to research. So now we talk about loneliness then. And as we all know, I think COVID has really highlighted loneliness through lockdowns and equality, and how important it is to have social connections that make sense and keep us happy. So most of us experience loneliness from time to time, but unfortunately, there's a small percentage, say 5 to 10% of people who always or often feel lonely. And these are people that are probably suffering in silence. And we hope that our research can help deliver ways and innovations to help get people out of loneliness. Loneliness is a psychosocial domain. It's very important. And it's well understood. We've had it for eons, actually. And we know that there are public health implications for loneliness. And crucially, we know that when loneliness becomes prolonged, it can inhibit social connection and cause harm. And it's one of the leading factors for a poor quality of life. So technically speaking, loneliness and social isolation are two separate things, but oftentimes they're used interchangeably. Loneliness is a feeling, it's an emotional perception that can be experienced by individuals regardless of their breadth of the social network. And this is the Public Health England definition. It's a subjective feeling, it's unwelcome, and it's just something you feel on the inside, rather. Whereas conversely, social isolation is an objective, it's something you can measure. It's the inadequate quality and quantity of social relations with other people at the different levels where human interactions take place. It's a measure of the numbers of contacts or interactions we have. So yes, they are different, but oftentimes people use them interchangeably. Now, there are patterns of loneliness. The best place to be is on the top left here of this matrix. You know, to be not lonely and not isolated. You're more likely to be like that if you are female, married, younger, you have children, you have a positive health assessment, you participate in social events, you don't feel sad or depressed, you have high self-esteem, and you're close to family. Whereas conversely, the worst place to be is here, where you're lonely and isolated, and you're more likely to be like that if you're male, divorced, single, and so on and so forth. And of course, there are other permutations of people feeling lonely but not isolated, and vice versa. There are a number of risk factors associated with social isolation and loneliness. I won't go through them, but some of them are socio-demographic factors, others are life events, for example, recent bereavement or widowhood, health factors, disability, and other factors as well, which you can see here on the slide. So loneliness is a public health concern. It's actually can reduce life expectancy by as much as smoking 15 cigarettes a day. It can lead to premature mortality. It can raise blood pressure. It can increase our risk of cardiovascular disease and so on. The government knew this, of course, and other governments, and the UK was the first country in the world to publish a loneliness strategy in 2018. The Prime Minister at the time, Theresa May, launched the first cross-government strategy to tackle loneliness in 2018, recognizing it's one of the greatest public health challenges of our time. And indeed, United Nations and WHO have recognized that, and there's a lot of work now being done by these non-governmental organizations. And there was a pledge back then, just before COVID, that by 2023, general practices would be able to refer patients experiencing loneliness to community activities and voluntary services through social prescribing. And I think we're beginning to see that happen. Now, measurement is the heart of science, and when we engage in that space, we wanted to understand, how can you know if someone is lonely? You could ask them, you can ask them questions, and they could respond. But here are some examples of some of the validated questions you could ask them that if they respond to, you will have a scale to determine whether or not they are lonely. There's the De Jong-Deerfield loneliness scale of 6 questions. There's University College Los Angeles 3-item loneliness scale, 3 questions. There's our Office of National Statistics direct measure of loneliness, 1 question. And there's the Campaign to End Loneliness measurement tool, which has 6 questions. Now, we thought it would be great to ask a large number of people some basic questions to determine how lonely they are, and then therefore develop a heat map of loneliness in the UK. Now, something like this was done in the past. The biggest was the BBC Loneliness Experiment, which recruited 50,000 people. And that was very good. So we thought, why not do that, but on steroids? Why not do that in a bigger, better way? So we decided to do a study that could reach a large number of people across the UK to help map loneliness across the nation, identify pockets of loneliness where people may be suffering in silence, and from that begin to do a lot of work. For example, engage with local authorities to understand what they could do to help people in their patch. We could look at developing place-based interventions, and we'll come to these later. So this is then the Measuring Loneliness in the UK, or Interact study, that I'm here to talk about. And this is the study team. I'm joined today by my colleague Eos, who is the Interact study team coordinator. Our aim is to create a heat map of loneliness to inform place-based interventions. And we want to do this by working in partnership with local authorities, community groups, NHS primary care, schools, care homes, voluntary sector organizations, and so on, to engage with a wide segment of society. And we're going to use an anonymous survey to do this. So the vision is to collect data from enough people so we can get a heat map of loneliness across the country at city level and at borough level. I'm going to pass you on to my colleague now, who can tell us a little bit about the instrument. Thank you, Eos.
Thank you, Austin, and hello all. I'm Aus, research officer at the South Korea Academic Research Unit. Been working with Austin and the team for 5 years, public health research, and also, as Austin stated, our study coordinator for the Measuring Loneliness study. So early on, we decided for the Measuring Loneliness study, we wanted to create a heat map of loneliness. So to do this, we decided to on an e-survey. So starting with this, we decided to split the survey sort of into 2. So the first half, the respondent is introduced to the study and also a tick box consent. We then ask the age, postcode, and gender, as well as the UCLA 3-item loneliness scale and the ONS direct measure of loneliness scale, the single item. And these items are actually suggested by the Office of National Statistics to measure loneliness. So with just block 1, we have everything we need to create the heat map. But if the respondent then follows on to the next page of the survey, we also have the social capital score and some demographical data. So, for example, whether they have pets and whether they're in contact with relatives or friends. And again, this block is actually optional, so they don't have to completely answer all of those questions. And then finally, we have the consent to contact for interview. So the respondent can leave an email, if they'd like us to contact them to express their views and opinions and experiences on loneliness. So to create this survey, we use the Qualtrics platform, similar to SurveyMonkey. So you just put the question in and it creates a desktop and mobile web page for you. You can see here we took the liberty to translate the survey into multiple languages. So if English isn't there first, there are 10 other languages that they can read the survey in. So you can see on the first image, that's just the introduction. As well on the second image, that's the tick box consent. And then if you just go to the next slide, you can see this is basically just block 1. So the full postcode, the 3-item UCLA scale, and the ONS direct measure of loneliness, as well as the age and You can't see it here, but also the gender. And again, with that, we have everything we need to create that heat map. So in terms of inclusion and exclusion criteria, we got ethics so that anybody aged 16 years and or over can participate in the survey. So again, yeah, favorable opinion from Imperial College Research Ethics Committee to recruit within the community. We also sought NHS Research Ethics Committee and HRA approval to recruit patients through GP practices and also to recruit NHS staff. Survey is sort of easy to be, can be accessed quite easily through mobile or PC or even tablet by scanning the QR code. The QR code, or please scan the QR code if you would like to complete the survey. So the QR code is displayed on the poster. So the poster was actually displayed across GP waiting rooms and the like. And also, you can also access the survey, I think. So GP practices recruited participants through sending them an SMS. So that SMS included the link to the survey. And yeah, we're also recruiting through schools, care homes, and other settings. I'll now pass back to Austin to discuss progress so far. Thank you very much.
Thank you, Eos, and thanks to Eos's help and your colleagues' determination. We recruited 142,000 participants so far, and from 15 different clinical research network sites across the UK, including 43,000 respondents from the NIHR Part of Research Network. This is basically a network of like-minded people who want to volunteer to be part of research. They sign up to hear about research that's relevant to them. And thanks to your group, because we recruited 8,356 participants from your region, thanks to the support of your CRN team. Our initial intended sample is 250,000 respondents. At the moment, we've got 142, but we're on our way to get that sample soon, and we hope to increase the sample to 500,000 by the end of the year. So just briefly to highlight some of the interim data. This is the age profile of our respondents. You could see that we are actually engaging with people from across the age groups, but there's an interesting dip here, and people who are between 40 and say 55, they're less likely to participate. That's interesting. I think perhaps because they're very busy, they're working, they're traveling, it may be less relevant to them. As you will see later, you could be in a classroom full of people and feel lonely, or at university, or you could be much older. But it's interesting insight here that we're not getting the normal distribution that we would imagine. But that's not a bad thing. It's just an indication that, this is a topic that we need to raise awareness about, and also it's relevant to different people at different times of their life. We're also surprised to find that this is a dot plot to show us, what do people say when asked the direct question, how often do you feel lonely? Well, actually, often or always, people who respond often or always are more likely to be younger. So that was surprising to us. You can see here that fewer people, it could be because there are, so interesting insights there. Again, this is interim data, but there seems to be a swell at the younger age. Whereas conversely, if you ask people, how often do you feel lonely? People who say never are more likely to be of an older age group. So if you're 70, 80, 60 to 80, you're more likely to say never. Perhaps it's because you've lived a long life, you have family, you have friends, you know how to cope with loneliness. We don't really know. There are interviews that tell us, but these are interesting high-level insights. We're also beginning to look at the data more quantitatively. This is an odds ratio calculation to say, well, non-London females have 17% higher risk for loneliness compared to males, generally across the UK. And so London females are 8% more likely to feel lonely compared to males. And across the board, overall, females have a 16% higher risk for loneliness. That's strange, actually, because previous literature has shown the opposite. You're more likely to report feeling lonely if you are male. But again, these are interesting insights we're sharing with you. Another two surprising insights is this. On the left, we show that being non-white, or people who identify as non-white ethnicity, have 25% higher risk of loneliness compared to white respondents. Again, that was surprising to us. But again, this is interim data. And also, even probably the most surprising is this. that employed respondents have 13% higher risk of loneliness compared to non-employed. Again, that is a very surprising finding. So we're interested to see what the final results will tell us. Ultimately, we want to develop heat maps. These are some examples we're beginning to generate. It's early days. I mean, considering there are 80 million people in the UK, we really want to collect data from 8 million people, 10%, right? That's a long way to there, but it's beginning to give us insight as to, you know, this is an example of a heat map of loneliness at local authority level. You could see here that, you know, there are different colors, so there are different levels of loneliness. It's interim data, so we're yet to do the full analysis. And we are grateful for UK Onwards for providing some of that mapping that from our data. This is a more detailed map of the 142,000 people that have come through to the survey. This is showing loneliness with respect to the median super output area. So this is a smaller area, and you can see here the interesting patterns as well. This is how London looks compared to Liverpool. Again, interim data, and this is a bigger version of London. And I think this is the most interesting slide, where red is bad and green is good. So you see here that there are actually pockets of severe loneliness. These are the ones looking quite red. The grey means we haven't got data actually from people yet. But you can already see that, I don't suppose there's a pattern, but there are definitely hotspots that we could work with. You say, okay, well, what are you guys doing here? What's the story? Is this what we expect? What interventions exist? And here's a similar picture across the UK. So this is where you are, Humber. I think, you know, showing a good sort of distribution, but there are actually, there is a pocket of loneliness that you can see here as red. So data is amazing. I mean, this is when data is beautiful. So we're working with a statistician who's going to be doing a rash analysis. It's a very deep statistical test to try to understand how each of the questions we asked relate to one another and so on. So we're excited by that prospect. And the future is going to be really trying to develop more heat maps and trying to get deeper quantitative insights. Ultimately, we want to be talking to people who volunteered to be interviewed. We already started the process to understand what they think could be done to tackle this problem in society. For example, to what extent can we leverage asset-based community development, or ABCD, to tackle loneliness? For example, cycling clubs, Zumba lessons, and other interventions. I don't think there's going to be a one-size-fits-all solution. You know that, depending on what age group you are, your background, and so on. But it's important to begin to unpick this. If you'd like to know more, please have a look at our website. We have a dedicated webpage for this study. It's linked below. We also gave a talk last year to celebrate Mental Health Awareness Week. And the talk was around loneliness in the context of the new society we live in. So pretty much like the steam engine transformed life and electricity transformed our grandparents' life, we can now see, or we've seen many of us, how digital transformed our life. But since COVID, we've had the introduction of artificial intelligence, cyber-physical systems, 3D printing, drones, nanotechnology, blockchain, and genetic engineering. And we think that this would also create a non-linear expansion of possibilities, and life will be vastly different by 2035, 2040. So, you know, what does that mean for loneliness? Interesting insights there, and I think this study is going to take us there. So to summarize then and conclude, loneliness is one of society's wicked problems that you just can't wish away by throwing money at it. You know, problems like suicide, loneliness, domestic abuse, violence, alcoholism, drug abuse, you know, you can't just wish away by throwing money at them. You have to do something deeper than that. And measurement is the heart of science. So obviously that's our focus now at Imperial, to make sure we get a good handle on the data. We, in fact, through the study, we want to raise awareness about loneliness and destigmatize it, making it everybody's business. And we hope that our work will help tackle this problem by potentially giving local authorities a handle on where hotspots of loneliness are, and inspiring them to get funding from charities and otherwise to do what they do best and intervene and help people where they can. So the heat maps we're producing are helping us to get a nuanced understanding of loneliness hotspots, and the rest is obvious. and our interviews with lonely and not so lonely people, because we're actually interviewing people who said, I've never been lonely. I just, I think myself out of it. We'd like to understand more about that. So not just meet with lonely people, but also interview people who are more resilient to that and understand what is so different with them. And finally, we're going to be using this data to synthesize some recommendations for the consideration of policymakers and local commissioners. I hope that was a brief introduction. Thank you so much for the invitation to present. I'm happy to take questions, Eos and myself. Thank you.
No, thank you very much. And we did enjoy the conversation around loneliness. I think loneliness is something that we in HO have taken it seriously. And I think last year we had a conference on loneliness. And one of our colleagues, Dr. Faiza Sheikh, has been leading the work down here on loneliness. And we invited Lord Mayor and everybody who's working loneliness. So we are happy to be partners in partnership with you in tackling this wicked problem. Any question from the audience? The hand went up a few milliseconds before. Okay, you go. Go ahead.
Hi there. I'm a speech and language therapist in the organisation, and I can see a lot of parallels with my own research interests, looking at people with language impairments and aphasia post-stroke, and I'm planning on looking at life after stroke outcomes for those people. So I know that a lot of my patients that I work with on a daily basis are lonely because they tell me that, because of physical changes that they've had, but also because of how their language impairments impact on their social interaction and then therefore cause loneliness. I just wondered if you'd drilled down into any of that kind of thing in your data, or more widely, what health conditions cause loneliness and how that impacts on things.
Thank you for the question. Really inspiring to hear about your work with people who need your support and who obviously are very keen to improve and maintain the quality of life. Truth be told, no, we haven't. We needed to keep this study as simple as possible. For example, we could have asked questions about, do you have any long-term conditions? What type of, do you have a disability, and so on and so forth. So we wanted to keep the survey short to ensure that people could finish the survey. Otherwise, it may detract us into important but not directly relevant things. So I suppose we may get examples of interviews where people would declare that they have a condition and so on and so forth. So there'll be some insights there, but no, we haven't been focused on this. I mean, truth be told as well, my focus was self-care. So this is slightly outside of the self-care bag, but still is very important nationally. So we wanted to do something that could make the right noise, raise awareness, at the time that, of course, with COVID and everything became very prescient. Although I imagine there would be other groups who are specialists in loneliness research and who would be able to engage with that. So it's our loss. We didn't do that sort of that deep dive, but I hope you understand this is more about trying to get a handle on, at the big picture, can we raise awareness? Now, what I didn't discuss is the limitations. We're collecting data over the year, different seasons. Some people may respond very differently in spring or after a bad day compared to autumn. You know what I'm saying? So seasonality plays an important part. Christmas is one of the loneliest times for people ever. So, there are many, many limitations, and this would be one of them. So not asking people about the conditions they have and so on is a limitation. But I hope that we can still use our data to raise awareness and develop something that could be used by the community and the scientific community as well to re-engage and have a new point of departure for how we understand loneliness at a national level. Like I said, this is the biggest study in the world now on loneliness, so this is a great accomplishment. And thanks to your colleagues' support, we have increasing numbers of respondents. So please do raise awareness about it. And I'm happy to be contacted should you want to do a sub-study specifically looking at some of your patients that would be interested. Thank you.
Another question in the room for you.
Hi, I'm Soraya Myatt. I'm a consultant addiction psychiatrist in East Riding. So I was interested in your view on throwing money at problems Because what we've found is, you mentioned addictions as well, but in terms of supporting vulnerable communities, people who are lonely, people who have domestic violence, addictions, actually the funding has really reduced drastically, and actually what services are provided at a much lower level. So I guess my question is actually maybe we do need to throw, or the government needs to put more money into these areas to actually support people, but hear your view. Thanks.
Thank you, Susan, for your intervention. And absolutely, I think if anybody's going to throw money anywhere, please give it to me. But I suspect that there's a lot of tokenism in some of the work, in that, policymakers oftentimes talk and they say there's this and that. But in fact, if you look at the budgets, like enormous amounts are spent elsewhere, and you think like, why isn't it? This is a root cause. It affects quality of life, like I said, young or old. So absolutely, I think there should be investment. Now, the WHO is doing some work. There's an international movement now. WHO has highlighted this as a public health concern, and you will find that governments are going to pick this up. We have a number of charities in the UK, like the Campaign to End Loneliness and others, that are committed to advocate for this. So yes, we hope more money, more funding for research certainly would be available to do what we're doing and what others are doing to continue to work on this. And unfortunately, because it's a wicked problem, I don't think that the problem of loneliness will ever go away. I think the best we can do is to keep it at the top of our agenda, learn how to become more resilient, and just make sure that we do what we can to help ourselves enjoy quality, and also others where possible. But quite right, we need more investment, we need more research certainly, and we need more engagement with yourselves and your counterparts who would show interest to help us recruit and to raise awareness and deliver place-based interventions that are bespoke to what your population needs, because there isn't a solution that works for absolutely everyone.
Thank you. I really want to thank you for making the time to talk to us. I'm actually fascinated by the results that is coming through, because my perception of loneliness is older, living alone, and I wasn't expecting younger people who are in education or in work to be the group that is reporting more loneliness. That's a show that is probably more perception than objective, and I would really want to see the final outcome when you have finished your work.
Thank you. I'd be very happy to share our infographics that will produce some lay summaries, and also our technical documents, our reports and papers. So thank you so much for showing an interest. I hope to re-engage with you, and maybe next year we can come back if you're invited to present some of the advanced outcomes. Thank you for your time and invitation to present.
Thank you, and your invite will be in the post for the 8th Hamburg conference.
Looking forward to it. Thank you, and thank you, EOS, for your hard work on this. I think EOS has been instrumental, and thank you very much.
Okay.
Thank you.
So we're going to share a video on our research in Hamburg when you're ready.
I was taking part in the environment study, everyone was really friendly and helpful, and I had a great coach who always had positive suggestions as to how I could move forward. She was really helpful. It wasn't difficult at all, and it didn't interfere with my life. It was nice to think that I was potentially helping others by being involved. It helped me realise my strengths and weaknesses, and by the last appointment, I realised I was managing my mental health quite well, but not my diabetes, unfortunately. So I know I need to work on that. I would definitely recommend it to anyone thinking of getting involved in research, and I would consider doing something similar again.
Hi, I'm Max, I'm 16 and I took part in 2 PPI courses that included mental health and gaming and its effect on children and teens. I found the best parts about it was that I was able to have a voice about myself, and I could say what I needed to say without being judged for it. I feel it's a relaxed atmosphere, and I had multiple like-minded people that thought a lot like me. And it was also where everyone could make their decisions and choices. I enjoyed doing those sessions, and they helped me notice what I was doing and how it was affecting me.
Hello, I'm Bobby, parent of Chloe, who is 10 years old, and she has a diagnosis of autism and ADHD. We have come to all of the events in the sort of co-production outside here at the beautiful Barlow Common, which we've ended up creating a physical resource pack to aid parents and children in getting their children outside, getting the adults more confident in coming outside, and putting tools together that we think would help both children and adults. It's been an amazing idea. We've been involved from the start. Research has also made the children feel really comfortable and really built up their confidence, and so her choice was, to sort of not really get involved and sort of just observe. And then even by the second week, she really got interested. She really enjoyed making. We made an outdoor maze for sort of clay, for little clay objects to get through. The photograph of that, which then featured in some of the prototype production, which obviously really cemented that for her to be able to kind of have that connection with the project. So I think that was really powerful. I wish the team the best of luck in the future, and I can't wait to see the pack, as it were, go live and everything else. Cheers.
morning, I'm David Brackenbury. I'm a consultant clinical psychologist working in the Forensic Outreach and Liaison Service, or FOLS, which is part of the Forensic Division. Our team work with people who have a learning disability and or are autistic and have come into contact with the criminal justice system. During 2023, we started the process to become involved as one of the sites for a national research project. This project looks at the effectiveness of a therapeutic intervention with men who have a learning disability and have engaged in harmful sexual behaviours. I'm the principal investigator for the local site in Hull. So I think our involvement in this research project has been a great example of working across different parts of the Trust. I was made aware of the project by psychology colleagues in the Learning Disability Division. We were able to support 2 staff from these services to access the intervention training. We've been massively supported by colleagues in the Trust research team to manage a lot of the tasks of getting to this stage. And we've then been involved in discussions with colleagues in both adult mental health and the community division for access to potential venues if required to deliver the intervention. All of that shows me that research is a collective effort. I recognise that we're just one small part in what is a much larger piece of national research, but locally to see all the different elements contributing to that small part has been refreshing and rewarding to be involved in.
Hi, my name's Caroline Scott. I'm a forensic psychologist working at the Humber Centre, and feedback we've had is that often participants enjoy being part of something bigger, kind of contributing to the wider knowledge base, thinking about, feeling part of something larger and that might be helpful for others in the future. And then liaising with the research and development department, who have always been really helpful and supportive with kind of raising any questions and working through those processes. So overall, it's felt really helpful and worthwhile being part of something larger.
Hi, my name's Anthony. I'm excited to talk to you briefly about my research experience. I've been involved in a number of researches in the past, the most recent one being the NALPAWS study, where we sort of looked at the effectiveness of naloxone administration by the local community members in reversing opioid overdose. I was one of the recruiters for this research, and it was an amazing experience for me. It helped me understand and interact better with the local people, as well as gain more in-depth knowledge. I'm hoping that you would make a decision today to join a research or engage in one, and I'm very sure you would enjoy it. Thank you.
So 2 things. Really, as exec lead for research, I'm really proud to see the breadth of research that is being done across the organization and the collaboration. And I can't help but to feel inspired to do research. And I hope you guys are also inspired to do more research. So let's have a quick break, come back at 3 o'clock, stretch your legs, have a quick drink. And then I'm sure that we have 2 more awesome speakers to talk to us about research, so please come back as quickly as possible. Thank you. I'm sure you've enjoyed the first session of the afternoon. I think one of the things that I kept asking myself was the harmful effect of loneliness was equated to smoking 15 cigarettes a day. So I was just thinking, if you smoke 15 cigarettes a day and you are lonely, then I was wondering what your options would be. It means that you're in trouble, much in trouble. That's a double whammy. So I've known Haley for a long time. Haley is very, very keen on research. So I'll leave the floor for Haley to share her experience with us.
Thank you. I'm not actually speaking about research. I'm speaking about an evaluation of a project. So, I'm called Haley. I'm a mental health nurse. I've got nearly 20 years experience with Humber, mainly working on inpatient wards. But the last few years I've had the pleasure of working with the research team as well. I've got 3 glamorous student nurses here with me to help with this presentation, and I'd like to talk about a project offering student nurses an opportunity to complete a split clinical and research placement. So the MESH project is a pilot scheme in which a number of mental health trusts across England are offering nurses the chance to learn about a research, a development and a delivery in the NHS. And as researchers, we all know how hard it is to engage nurses, to recruit and work on studies, whether it's a lack of interest, a lack of time, a lack of confidence. It's really a problem as researchers often rely upon nurses to identify potential participants, help recruit or deliver interventions. So the aim of the MESH project has been to challenge the preconceptions about research and educate the nurses of the future to build a workforce who not only are recognising the benefits of research, but will actually engage and support research growth moving forward in the future. So the impact of the project and the student experience is being evaluated by senior research leaders, and one of whom has recorded a clip about how and why we need to engage nurses in research.
Hi everyone, hope you're all having a great day today at the Humber Research Conference. My name's Sarah Daniel and I work at Tees Wear Valley's NHS Trust as the Head of Research, and I'm also one of the NIHR Senior Research Leaders for Nursing and Midwifery. My professional background is as a qualified nurse, and I started my research career 27 years ago as a research nurse working in Newcastle. This makes me feel quite old, as I'm sure some of you in the audience weren't even born 27 years ago. Anyway, I'm delighted to share a couple of slides with you today about why research is so important for nurses and how this links in with some of the great work which Hayley and others here at Humber have been leading on. Nurse involvement in research is key given the integral role that nurses have as part of day-to-day delivery of healthcare. And in November 2021, the Chief Nursing Officer, Ruth May, published Making Research Matters, which was England's strategic plan for research. The vision is for a people-centred research environment that empowers nurses to lead, participate and deliver research where research is fully embedded in practice and professional decision-making for public benefit. The Nursing and Midwifery Office at the NIHR, which is led by Professor Ruth Endicott, has also received a boost in funding to help nurses and midwives develop research skills and knowledge, which has led to a number of new initiatives. One of these initiatives is the Research Careers Framework. This framework provides an overview of how nurses and midwives at all stages of their career can become involved in supporting, delivering and leading research, and a suite of initiatives and resources is available on the NIHR Nursing and Midwifery Office website. One of the key areas of focus is building research delivery opportunities and awareness at the earliest stage of nurses' careers and during their training. So Hayley's going to go on and talk about the MESH programme and how Humber have been a part of a group leading the way to embed research in student nurse training. Thanks everyone, and hope you enjoy the rest of your day.
The research team would not have been able to offer split placements without the help of the University of Hull. This is quite a new way of placing students out in practice, and although it's had some minor teething problems, as this conversation shows, the university have viewed the project positively.
Hi, my name's Caroline. I'm the Programme Director for Mental Health Nursing at the University of Hull.
Hi, my name's Gemma. I'm the Programme Director for Learning Disability Nursing at Hull.
And we've been part of the project, haven't we, Gemma, about providing some specialist placements, and we've been really excited to work with Hayley and the research team to open up a split placement for our LD and mental health students.
Absolutely. And it's been an invaluable experience, I'd say, for not just the students, but for us as well, in terms of developing our relationship with practice and how we can develop new ways of working and continuing to give different types of experience.
Yeah, it's so invaluable having these types of placements for undergraduates and letting our nurses know that their career can be in research, which is fundamental to our professions.
It is, and it's worth mentioning that our students are quite nervous whenever we mention the word research, and they don't really believe that it's within their capabilities. One of our students in learning disabilities was quite worried and said the words, "I don't think I'm clever enough." However, when she did the placement, she realised that was a very different experience.
Yeah, and that's really down to the support from Hayley and the team as well, in that helping students to feel comfortable in starting off their knowledge base, if you like, their limited knowledge, and expanding on that. And the types of students that we tried to recruit, we try and be as inclusive as possible, and that's an ongoing discussion between us and Hayley, really, isn't it?
Yeah, I think it's worth, mentioning the recruitment process in itself that has certainly developed over time, and we've realised that we need to give a lot more information to the students so they understand what it is that they're going to undertake, and also get the right year group. I think it's really important that we know that third year students are probably a really good year group to capture this, but that we put it at the right place so we're not taking away the management placement. So getting things like that right has been quite an experience.
Yeah, it has, hasn't it? And making sure that the complementary split placement to the research team has all the knowledge and the support that their practice assessors and supervisors need to be able to make sure that the learning opportunities are set at the right amount as well, not for the student not to be overloaded or feel that they're overwhelmed. And I mean, luckily, because we have these relationships, we've been able to sort of problem solve as we've gone along, really, with a lot of things. And the learning from that has created how we do things slightly differently the next time round for recruitment, hasn't it?
Yeah, I fully agree. I think one of the concerns that the students did have was, how am I still going to meet my proficiencies? Yeah, I think one of the other benefits that I've certainly seen with our students, I'm sure you have with yours, is that increasing confidence and that understanding that, okay, I'm a nurse, but actually I'm part of this research and I need to be part of this research. I don't think that ever crossed their mind before. They heard research and they thought, okay, I need to go ahead, I need to go and do another degree, I need to do some more education, but actually to understand that they have a role.
Yeah,
I think that's
so they're part of it right from the beginning. It's within their gift. It's not something that's abstract or something that researchers do. We can all have a part in this and to create that sort of new evidence for our professions.
Yeah, so I think going forward, we need to absolutely continue on this. We need to involve more students. The feedback we've got from the students will help us to do that. Their testimonials will help us to recruit more students, and it needs to carry on.
Yeah, definitely. Thanks to Hayley and the team for giving us the opportunity at the University of Hull to do this.
Absolutely.
Thank you.
So it's not only the university who've been involved in organising the placements, the practice education team who have not been able to join us today. They were going to talk about MESH as being a collaborative process, and that their team has actually worked closely with the university to help them allocate students to clinical teams who've been agreed to accept a split placement, because obviously it impacts on their clinical experience as well. But the education team have told me as well, it's also opened up placements in teams who haven't been able to take a full-time student. Teams like the Adult Autistic Diagnostics Service and the Speech and Language teams are willing to take a student part-time. So perhaps in the future, as we're moving forward, we're looking at offering this opportunity to allied health professionals. To date, the project has had two groups of students so far. We had a group autumn 2023 and again spring 2024. The project offer is for a small group of students to spend 2 days a week of a specified placement with the research team. We have a structured timetable, and that involves a half-day teaching session on a face-to-face basis where various members of the research team come in and speak to the students about their roles and responsibilities of their experience in research. The students have access to online learning, can attend research meetings, and have the opportunities to accompany researchers out in the field. The timetable covers topics which range from how research is organised in the NHS. We look at creating research about co-production involving people in research, and we look at the projects that the team are working on at present as well. The overall aim is to show students that you don't need to be able to read an academic paper or understand the statistics. Just by being aware that Humber have got a research team and how to contact us is sometimes enough. So I just want to hand over to the three of the students who took part in the first group.
Hi everyone, thanks for having us. I'm Charlotte, I'm a third year student mental health nurse.
I'm Kerry, I'm a third year learning disabilities nurse.
And I'm Lindsay, a third year learning disabilities nurse as well.
So we're just going to talk you through a bit of our experience that we had on this placement and how really it's inspired our last of our studies and our future careers. The first thing I've got on there is the GCP training, because that's pretty much one of the first things we did. We did our good clinical practice training, and not only was this like amazing experience to give us a very in-depth overview of research and how we can get involved and what's needed, but it also meant that we were able to go out and support those studies. So we actually got quite hands-on with the team. The team were really welcoming and invited us out, but it meant we could go out and we could support those studies. We could see how our previous experiences, our education could feed into this research, looking at things like capacity and consent. And it's actually also fed into our university assessments as well, because we're doing a bit of research for our final projects, and that underpinning information and knowledge of research and how it works in healthcare, I know personally, I'm sure it did for these guys as well, helped with that final project and gave us a bit more understanding and actually gave me a bit more drive. And I left this placement with already inspired to be more involved in research. And actually when I've gone back and I've gone and done my assessment, thinking back to this placement, and it's amplified even more. One thing I would mention is it was mentioned by Carolyn and Gemma. We're talking about speaking with the most appropriate teams for placement split. And one challenge I had, which I think everyone on the placement got fed up of me talking about in the end, was my personal placement split didn't really work because I was split across 3 teams in 8 weeks. It was quite intense, but the team immediately took that on board, and I could see that they were listening, and that was taken into consideration, not only by the practice education team, the university, but the research team and Hayley. And really nitpicking, trying to find anything that could have been improved, would have liked more hands-on experience. But again, it's only 8 weeks, we only had those 15 hours, and it's down to staff availability and what studies they had on at the time. I'll hand over to Lindsay.
I'd just like to start actually by thanking the research team. You really embraced us and let us join in anything that we could do. And I'd like to really say a special thank you to Hayley. what Hayley doesn't know, honestly, is not worth knowing. She's a really inspirational person to know. And I'd just like to say thank you for having us, and we really all appreciated you. I would say the experiences that I got out of the research project were actually the peer support that we all got together. It was about the networking that we did together, and ultimately it really helped us look at things across different disciplines, which sometimes we work very much as part of multidisciplinary teams, but not necessarily across the field. So we shared experiences and we shared ideas and took things forward in each of our individual fields. That's all I've got to say. Thank you, Kerry.
And I'd just like to say I was the person who Gemma said I was really worried that it'd be too academic for me, and I couldn't really see where I would fit into a research team as a student nurse. But the overall experience was really good, and it demystified research to me, to the point where I've signed up to be a research champion, and I can't wait to get out there and identify people for trials that are going on. And I'll pass back to Hayley.
That was wonderful, thank you. Okay, so I guess just to conclude that the hybrid placements are proving popular. As I told you earlier, we were perhaps in early discussions about offering it to students in other healthcare professions, and we're happy to take any questions or your thoughts.
If not, would you want to speak? Oh, Mike is here.
Hi, I mean, this sounds just wonderful, really, what you've done to support nursing students getting into research, and just to hear the students and what you've said and what you've learnt from it, it's absolutely brilliant. So just really fantastic. And maybe I was just thinking from my other side, Director of Medical Education, with the medical students, like in terms of electives and things, it might be something interesting. I don't know, but to think about that for the future. So, yeah, but fantastic work you've done.
Maggie.
Hi Hayley, I think the work that you're doing is absolutely fantastic, but I'd like to ask you to branch that out into adult nursing as well and community nursing, because I think there's a need there. We do take on third year students because we know that they want to have a career in primary care, so this is a really good link. So I'll be sending you some names across, okay?
Yes, I think the comment about Hayley was good, and I think that was my thought as well, to say whether we need some medical students to get affiliated to the research department, because I think I took the cue from what you said, and most people who have gone on to do research into bigger areas always start from either nursing student or medical students. So I think if you make people excited about research at the beginning of their career, majority of them go on to do research. So thank you for what you're doing, Hayley. Okay. And thank you to the students for coming out to talk about it. So Liz is talking about the stories of living and working with risk from child and adolescent mental health services.
Finally. Yes, I'm a bit scared of the microphone, but I'll try not to shout. My name's Liz Darwell. Very happy-ish to be here. I've really enjoyed all the presentations and just hearing about people's journeys into research, really. This research study was conducted as part of my professional doctorate in systemic practice and research, which I undertook at the Tavistock and Portman down in London, but the actual site of the research was up here in CAMS in Humber, which is where I work and have worked for about 17 years now, I think. Started off as a mental health nurse with Hayley on an inpatient unit, and then did my family therapy training about 10 years ago. And I work in CAMS. I've also got a bit of a split post. I'm also a psychological professions workforce lead across Humber and North Yorkshire. And the study is, I'll move the slides, that might help. The study is about living and working with risk. And risk is an extremely broad but important area, I would argue. And there is currently quite a big shift taking place in mental health services regarding risk practices. So this study, I think, has come at a really interesting time of change. And although it took place in CAMS, I hope that there's much that's come from it that's relevant more broadly across health and social care fields. So I'm a bit worried that I'm going to overrun, but I'm going to go through why the research was needed, in my opinion, how I went about conducting the research, what I learnt, and what it means for how we go about working in contexts of risk, and share some stories from my participants. Obviously, we've heard some really interesting stories of research. This was I'm a lone researcher, and it was part of a doctorate, so it was really important to keep it sort of small and contained, and that I wasn't ending up drowning in data. So why was this research needed? Well, it has been highlighted that some of our risk management practices can cause inadvertent harms, indicating that a change in approach is needed in how we manage risk. So this was an example of this was reported in the National Confidential Inquiry into Suicide and Homicide in 2018. And the conclusion of that report was that our attempts to categorise risk were an unhelpful way of guiding the treatment and management of clients, and that also it offered poor predictive value. We then had the NICE guidelines in 2022 on the management of self-harm, and that clearly advises against the use of risk assessment tools and scales to predict future harms, or to determine who should and should not get a service, or who should be discharged. However, I would argue that changing risk practices is really challenging. And the premise really of this research is that this is in part because suggested changes often do not attend sufficiently to the fact that risk is not just a set of practices, but is actually a discourse. It's a way of thinking that's influenced by broad cultural ideas. So in this way, questions need to be asked that enable us to really understand risk in a broader cultural and political context, not just as a set of practices. So through this study, I really wanted to try and understand the power and the influence that the risk discourse exerts. So not simply to see what risk is and how to tackle it, but what risk discourses do and how they might be positioning us as clinicians and what they might be inhibiting. Sorry, paper, it's not very technologically advanced, is it? This research was a qualitative study that drew on the interviews of 6 participants, 3 mothers who all had children supported by CAMS, and 3 clinicians from within CAMS. So I was definitely looking for depth rather than breadth. And the interviews, they varied in length from an hour to 2.5 hours, some of them. They were unstructured because it was really important for me that I gave space for participants to share what was meaningful to them, and to really focus on the bits that mattered. I didn't want to hem people in. The interviews were then transcribed and analysed using a methodology called dialogical narrative analysis, which I would be surprised if anyone's heard of because it's a bit niche. But it's basically a methodology that helps to reveal not just the content or the themes within stories, but to really try and expose what stories do, so what effects they have, and things like what do stories need to even sort of be out there to be sort of for people to connect to them, whose voices might be dominant and whose voices might be marginalised in the stories. So yeah, obviously there were threads of shared experiences with the mother's stories. All their stories spoke of a mother's love and a deep commitment to their child, which gave rise to an array of emotions triggered by the belief that their child was at risk. I would say that they all, at times, felt very reliant on mental health experts to bring safety back, but there were times when they had to find ways to trust in what professionals were doing, when at times they were faced with sometimes unhelpful or negative experiences. Try and breathe. And the children, obviously, by default, their stories appeared in the research, had all engaged in risky behaviours involving self-harm or suicide attempts. And risk, I would say, was felt to still be very much present at the time of the interviews. The clinicians were all very experienced CAMHS clinicians, spanning the disciplines of psychology, family therapy, and then one of them was a nurse and a social worker, sort of dual trained. And I would say that all their stories really highlighted the double binds at play when operating within the risk discourse, often this leading to a sort of unrealistic expectation or perception of what was achievable, what it was possible for them to know or to do or to be able to control. I was going to read some stories, but I think I'm going to run out of time, so I might have to skip, unfortunately, unless... if we've got time at the end, I'll come back to them. So what did I learn? Well, this was a bit challenging to put on one slide because, condensing this, I learned so much, a huge amount. So I've really picked out some of the key themes and ideas that really struck me. And the first thing really was, interestingly, risk was not always the central character in the stories. And often what was more intolerable and in need of attention was the presence of fear. And fear was often the force that pulled people together or pulled people apart. The fear was often about not being good enough, capable enough, knowledgeable enough. Fear often led people to question their ability to know their child, to question their expertise, or significantly, fear would drive people to self-protect, no matter what the consequence or the cost. So often the participants would say, it might not have been helpful for them, but it made me feel better. I guess a bit of an unhelpful consequence of the risk discourse was that it seemed to offer that containment of fear by absolving people of often unbearable levels of responsibility. And that was apparent really in both the mothers and the clinicians' stories. This next bit, this may seem really obvious, but it was really striking for me that safety is often seen as being the opposite of risk. In this way, when a situation is made safe, then the risks must surely have been reduced. And the participant stories really suggested something very different to this. And one of the participants said to me, the funny thing about risk is that risk is still here. Risk just moves, it doesn't stay the same. but things are safer. And she even struggled with that, like as a concept. How can that be? And through the stories, we really heard about how and when safety started to return. And it often returned despite risks still being present. And really throughout their stories, risk presented like shifting sands. And therefore the question for me became, if risk, what did the question become? I've lost my space, sorry. So yeah, if risk is not necessarily the most helpful focus, oh no, hold on. Yes, and when it can be so, yeah, is risk necessarily the most helpful focus when it can be so difficult to grab hold of? And if safety is not contingent on it, then, you know, is that the territory we need to be in? So this connects us really into another powerful thread that ran through the stories, and that was the work that expertise performed. And expertise came through in the stories as something that was simultaneously needed, helpful, wanted, but potentially actually quite harmful. In this way, expertise was a bit like a double-edged sword, and the mothers' stories all revealed, and hard to hear, but almost a colonising of motherhood taking place, and a real annihilation of their ability to be able to connect to their expertise and their intuitive knowledge of their child. And regaining their expertise, it did happen, and it happened in different ways. Sometimes it didn't seem to be noted, sometimes it wasn't necessarily supported, but just seemed to happen. But the thing that felt really significant is that reclaiming their expertise was hugely significant for their child's safety. So the clinician stories in terms of expertise revealed really the complexity within their idea and their kind of felt notion of expertise. And I think often the certainty and the decisiveness that's required from the risk discourse sometimes really undermine their sense of what was reasonably possible for them to know, or to achieve or to deliver through their expertise. You know, what is it? If we can't grab hold of and manage risk and control it, then what is it that we're bringing to the table? So needless to say, expertise really presented as a problem in need of further consideration. And shared responsibility, probably unsurprisingly, came through as being really key, but also was quite problematic when operating within risk discourses. And what seemed to come through in the stories was that this was often because of the motivations underpinning the drive to share responsibility. So it often became a way of stepping away as opposed to stepping in, of reducing one's own burden as opposed to diminishing someone else's. And this is maybe because a key function of risk is to position people as experts and decision makers, and ultimately to hold people to account. And this produces huge amounts of anxiety because risk is not out there in an objective realm. It's not something that we can capture, but is something that in the very act of perceiving it, it changes and shifts. And research does highlight that different factors will affect risk perception and thereby our variable responses to it. So where there's risk-taking and risk aversion, there will be this manifestation of shared confidence and shared fears, all shaping the dialogue of how we move on together. Okay, how are we all doing? So what does this require from services? I would argue that this idea of expertise is really key. It's often seen as necessary when safety is compromised, but can create unhelpful and unequal power relations, which can serve to leave people feeling disempowered and disconnected to their stories of competence. I've been reading about the concept of relational expertise, and that really came through in some of the clinician stories, whereby expertise is seen as something that becomes socially negotiated and is interconnected. So rather than the interest being on what we know, the interest becomes on how we jointly construct knowledge together, whereby everyone's expertise comes to bear, and how we work to promote inclusion and how we remain invested in the dialogue and ensure that other people remain invested in the dialogue and that their voices are heard. And the parents, this second point, was really key for me and almost quite disappointing as someone that works in CAMHS, because parents of children in CAMHS should be seen as an integral, needed and required part of the dialogue, because safe enough individuals require safe enough contexts, safe enough relationships, safe enough lives. And throughout the mother's stories, I was reminded that they were often not the person of concern, the person that mattered. One of the mothers described how everyone they saw was for their daughter, and they didn't have time for her. And at the end of her journey through CAMHS, she said to me that she was left feeling like half a person. But her daughter's, you could see through the stories, her daughter's safety was contingent on how she was doing. If she was doing okay and she felt connected and she felt that she could manage, then things were much better. So the focus for CAMHS, I would suggest, really needs to change. And when we did see safety being developed, it was in the relationships that this happened, not in the individual. So not only the relationships between parents and clinicians, but relationships between clinicians and between clinicians and parents. So really the stories from this study have opened up the potential offered through practices that invite inclusion and reduce power, and where the focus becomes the how of how we come together and coordinate our activities. And I would say that in the participant stories, when risk was accepted actually as being part of life, a part that needed to be heard and witnessed and understood, not necessarily scaled or managed or squashed, it really opened up ways of making those difficult aspects of life more livable and more tolerable. So we witnessed people and lives becoming safer and more livable in response to enhanced connections, dialogue, reduced fear, greater understanding. So risk often remained unknowable, but the relationships were robust enough to tolerate it. Am I doing all right for time? 10 minutes. 2 minutes. Okay, I'll skip to the last stage. From this research, I've put together some of these questions inspired by Vicky Reynolds. I don't know if people know Vicky Reynolds. And I would argue that we really need to ground a new approach to risk in a commitment to humanity and relationships. And to do this, I would suggest that we need some new principles. We need to move away from managing risk and to think more about what's required to structure safety. But what I would say is that this requires not just a change in practices, but a change in culture. We need to develop an effective commitment to ideas about responsibility, to acknowledging the fragility, the vulnerability, the precariousness, the humility, the uncertainty. These all need to be brought to the fore of risk governance. They're the stories that we need to be hearing. So these are some questions that I was suggesting that not as anything definitive, but as a start to change the kind of stories that we're generating, questions that we might pose to each other in our teams, in our supervision, to try and really connect to more authentic and self-reflexive accounts of what it means to try and nurture safety in our relationships. And I just want to end with one of the participants one of the mothers, and she said to me, this is a quote, "Well, you're the parent. You've got to manage the risk. If I had £1 for every time that was said to me, I would be rich." Basically, what they are saying is, if your child takes their life, you haven't been good enough. And they put in letters things like, "Mum is aware of the risks." But that's meaningless. What does that even mean? But the practitioner that has worked really well with us, she has never said, "You must do this, you must do that." And they've also said, "You are the mum, you know your child, it's okay for you to decide." But they have never said, "Well, the risk lies with you if something happens." That's when you start to feel empowered as a parent. It is the fact that I have learnt, and she has learnt, her way of letting me know what she needs. Okay. Thank you.
Excellent.
I'm not a natural speaker, in case you hadn't noticed.
This was well delivered, actually, because you were trying to tackle, again, another wicked problem of risk management, dynamics of risk, and the balancing between safety and risk, which is so difficult in clinical practice, in spite of what everybody thinks. Any questions? David.
Thank you. Elizabeth, that was great. Thank you. And you're probably a better speaker than you think. I'm David Smith. I'm one of the associate non-execs on the board. Your talk really got me thinking. The stuff that you talked about relationships. I mean, in mental health care, we've known this for a couple hundred years from the stuff that Chuk did over at the retreat, and we kind of lose it along the way, don't we? I had the real privilege a few years ago working on the team that kind of pulled together the new community mental health framework. And the risk conversation was kind of front and centre there, and this kind of push from teams across the country to have kind of some definitive risk assessments that we could do along the way. So it's like this comfort blanket that we keep reaching for. And I'm curious, kind of, did anything come out of your research around kind of what can we practically do around giving practitioners the safe space that they need to take risks in rebalancing this risk approach? The fear that people have of regulators, of kind of professional bodies, of litigation, it seems to kind of freeze us from doing the stuff that we know would just make sense. And I'm just curious, kind of what came out of the research? Is there anything that we could use in Humber to try and kind of just shift this back a little bit further?
That would be good, wouldn't it? Yeah. I mean, I think there is some really good work that's going on under the safe hands of Tracy Flanagan in terms of really trying to move us into a different discourse. Because I think when we talk about risk, we're then organised around preventing the worst from happening rather than trying to attain something good. And I don't think it's a helpful focus for us as clinicians or for families. And I think, trying to shift into a different discourse, really, and different language and different ways of talking and thinking about what we're experiencing, because risk is not a thing. People live unsafe lives, and sometimes we need to really be alongside them in that. But how the organisation holds us, and we move away from blame cultures, which again is part of the risk discourse, is really key. So I think it's about how we support each other and just have more honest conversations about what territory are we really in. I don't know if that's an answer, but that's all I've got.
Thank you very much. I don't see any hands. Thank you, Liz. That's so fast. So thank you. I'll hand over the mic very soon to Caroline. But what a journey this afternoon. So we have gone from AI, from Sheffield on techno-speech, which is supposed to help us with clinicians to be able to diagnose dementia and to support people with dementia in early stages. We then went to London, where they managed to try to tackle the wicked problem of loneliness and they have creating a heat map which literally seems to turn all the data that I knew, saying that things like women are more lonely than men, younger people are more lonely than older adult people, which is almost turning it around. But it was interesting to see, and then we've come back to showcase the breadth of research which we do in here, and then Haley and her students showing what you could do if you start diving into research early. And last but not the least is Liz trying to make sense of the cognitive dissonance that we have with safety and research. It is one of the things which exercise all frontline clinicians. When I work in crisis teams, sometimes you were not sure whether we were assessing based on fear or we were assessing based on management, and that debate continued to happen. I'm glad that you're starting that debate. So thank everybody for bearing with us this afternoon, and those of us online. Caroline, the floor is all yours.
Well, thanks very much, Kwame. I mean, what a day it has been. I just wanted to start by, and I'm sure many of you will agree with you, not all of you agree with this. I mean, starting the day paying tribute to Wendy, but also seeing the video that Wendy was involved in, and all her work to support awareness around dementia and the importance of research. To have Wendy in her, I think, late 60s, and then Evan, 12, as someone else who was inspirational with his mum, Lisa, about actually both the joy and the sense of purpose of being involved in being a clinical participant. It was just incredible, I think. And some of you sort of in the breaks were just blown away, I think, by those two contributions today. And I'll say a little bit more in a minute just about the potential of so many people from diverse backgrounds wanting to help, wanting to be involved, and they're there for the asking. And if we don't ask, we won't get. And I think one of the things about today has been in the sort of breadth and diversity of all the contributions we've had in terms of the very, very different research projects that you've heard about today, a really crucial element of each of them has been about, well, actually, how do we make this more than an academic exercise? How do we engage it with actually people we can help? And I think for me, a couple of quotes which I wrote down that came out of a couple of the presentations was today really struck me. One was from Louise's presentation about, I think, quote, research and innovation makes a difference. I think it was on one of the slides. And I think that is so important. I almost feel like we should just talk about research and innovation in the same breath, actually, because it gives it a dynamic, and I think Rowan's thing about movement, a certain movement in of itself, because, you know, the research is one thing, but actually what does it lead to? How does it lead to us thinking differently? How does it contribute to innovation? You know, and I think that is absolutely vital in all of this, which took me actually to Soraya and her contribution at the start of the day, in which I don't know whether you said it, it's been quite a long time since you started earlier today, but I quote, again wrote it down, is when research ends, what happens? When research ends, what happens? And again, I think what was fantastic about today was just having a sense, we might not be at the end of the journey, but there was a sense that things were happening. And I have to say, as a former government minister in various different departments, I literally hated the word pilot. I literally wanted to ban the word pilot from everything, because one of the things we're not good at in this country is actually, I think, spreading good practice. And when any of our pilots set up, I almost have begun to believe, well, before we commission that pilot, we need to have a sense, well, if actually it works, what are we going to do next? If it actually proves that it can make a difference, we have to have, for want of a better phrase, an exit strategy or a continuous strategy as to how we can make that real. There's too many people in public policy areas, you know, coming up with really good things that work. And that's one of my favourite questions is what's working, and my other favourite question is what is the point of this? And you might be saying that about this speech right now, I don't know. But one of the things is about how we share best practice and stop reinventing the wheel. actually, because another element of today, I felt, is while it was both innovative and interesting and new ways of finding information, some of the things that were being said amongst the different projects, I think we probably felt, yeah, we sort of know that. Why aren't we doing something more about that? About children being able to play, about children being in the outdoors. We know that all these entreaties to do physical exercise, often just people think it's too much we're asking of them. So actually, what are those small changes that make a difference? And how can we learn from the sort of research projects we've heard today about making something that people can feel they can both access, but let's be honest about it, sustain and progress within as well. As well as being chair of Humber, I'm also chair of the government's advisory committee on fuel poverty, and we're a small group, and basically we monitor the statistics on fuel poverty, and we work with stakeholders to look at how best we can address this problem. And it's a massive issue, and it has huge implications for health as well, both physical and mental, if people are not keeping warm enough, or we call it energy distress, actually, because they just can't afford their bills. And we actually have the opportunity as a committee to commission research as well. And our latest research project, hopefully, is going to be published later this week. We wanted to look at the journey to net zero and how do we make sure that that is a fair transition for those in fuel poverty. Because I'm afraid, for all the talk about net zero, often it's left out about, well, how do we take people who haven't got basic insulation in their homes on this journey? How do we take people who actually can't afford to pay their bills and are in debt, who are actually self-rationing on their energy, to net zero? So we're hoping that that project, and well, I've seen some of the findings, will actually show what both the enablers and the obstacles to do that, and how better, whether you're an energy company or a health organisation or what have you, can identify and help make sure that that journey is for them as well. I also like taking part in research. So, Catherine, I need to know what I can take part in. I have actually been, when it was on TV on Channel 4, a regular on Steph's Packed Lunch, and I took part in the, let's just get this right. Yeah, it was a big poo review, and basically I was one of 140,000 people who basically filled. I didn't send anything poo. I have to do that through my bowel screening program. But anyway, I filled in a questionnaire about my toilet habits, my age, my profile, all of this sort of thing. And actually, it created the UK's biggest ever poo survey to tell us a bit about, this part of our lives, which we all have to do, and how it affects, and provided that data and research for understanding gut health and how it affected our health. And just a few things from that. The average Brit does at least once a day have a poo. 1 in 400 Brits poo less than once a week, and people in Westminster spend most time on the loo. Huh. As if we didn't know. As if we didn't know. So, and again, I say that because, 140,000 people took their time to do this. And one of the great things, and just one of the most fortunate things about the National Health Service and the British public is we have this huge capacity in such a diverse number of ways to actually provide an opportunity for the British public in all its diversity to actually help us make a better health service, and in doing so get something for themselves, but also for something as others as well. And again, as an MP and today, working with Humber, I just know how many people I've met over the years who came to me, sometimes with a problem and something in the health service or what have you. And, more than anything, they came to me to share what had happened, not because they were looking for blame or something, but because they wanted things to be better. They wanted to be heard and understood. And I really recognise, Liz, your last contribution about parents, where children, particularly in mental health services, or even I would say adolescents, and particularly often that cusp between moving from children and adolescent services into adult services, how much they want to also be seen as an important part. And actually relationships is so key to that. But, actually people just want to help. They do want to pay it forward. They do want to enable services to be better. And even if they've had a bad experience, to share that in order so that the services can be improved for the next person who will be coming along. And I think the other aspect of what we've heard today that has changed so much, and I'm not saying it's just a UK thing, I think probably, many decades ago, and maybe not so long ago, research was, something was done to people. And I'm afraid there are some horrendous stories of clinical research that was done to people. But actually we've moved on enormously since those days. And actually it's with people we can provide a better outcome and a better service and get, I think, some joy out of it. That actually in all our lives, learning, thinking differently, doing something differently is a really good thing. It's a really good thing to enable people to get new life, if you like, new vigour about their purpose and what they're doing. We've heard from people today who have worked in the health service for a long time but have changed course, and this has enabled them to do that. And that is all really, really, really healthy. Finally, to say we will be back next year. I don't quite know when we'll be back next year with the conference, but Catherine assures me we will be back next year. Thanks to all the speakers today, to all of you here in person online, particularly to Catherine and to Alison Green. Is Alison in the room? Is she outside still working? Someone where's Alison? Alison! She's there. Come in. The light is shining in my eyes. I can't see you. Come forward, Alison, please. Come on, up to the front, let's see you. Yeah, well, so Alison, just on behalf of us all, thank you, because I know, without you, this wouldn't be happening. That's right, isn't it, Catherine? And thank you so, so much. So I hope you've enjoyed it. I have. It's been a pleasure to be here again, and I wish you all the best and safe journey home. Thank you.